Welcome to This Week in Health IT, where we amplify great thinking to propel healthcare forward. My name is Bill Russell, healthcare CIO coach and creator of This Week in Health IT, a set of podcasts, videos, and collaboration events dedicated to developing the next generation of health leaders. If you missed our live show, it is only available on our YouTube channel. What a fantastic conversation we had with Director for David Muntz, Sue Shade, around what's next in health IT. You can view it on our website with our new menu item, appropriately named Live, or just jump over to the YouTube channel. And while you're at it, you might as well subscribe to our YouTube channel and click on Get Notifications to get access to a bunch of content only available on our YouTube channel. Live will be a new monthly feature only available on YouTube. How many times did I say YouTube in that paragraph? Subscribe to YouTube. We're going to have some great stuff over there. This episode and every episode since we started the COVID-19 series has been sponsored by Sirius Healthcare. They reached out to me to see how we might partner during this time, and that is how we've been able to support producing daily shows. Special thanks to Sirius for supporting the show's efforts during the crisis. Now, on to today's show. All right, today we're joined by Dr. David Benzema, friend and advisor to the show. Good morning, David, and welcome back to the show.
Good morning, Bill. Thank you for having me.
Well, I was trying to think, who could I have this interested? I had this idea for a show, and I was trying to figure out who I could have on the show to actually do this. And you are the perfect one to do this. What we're going to try to do is something a little different, a little off the track of health IT. We're going to do a little point counterpoint and try to capture the current sentiment of the discussion in the U.S. What I'm picturing is a conversation between a patient who just lost his job and wants to go back to work, represented by me, and his physician, represented by you. And so we're going to do a little point counterpoint. This is going to be an imperfect conversation from two imperfect people as we explore really the handling of the pandemic. And I would just ask people to give us a little grace here. Don't hate the messengers from either side. Really consider the show as a time capsule for the conversations that are going on all over the country. I actually went out and hit social media, collected a bunch of the stuff straight from social media. I called some people that I know were not happy with the shelter in place and whatnot. And I said, all right, if you were sitting across from a doctor, what questions would you ask? So I actually did a fair amount of research to get questions word for word from the people who were asking them to try to make this as authentic as possible. So let's start with the most obvious question, which is, what do we really know about COVID-19 at this point? Things around transmission rate and lethality and those kinds of things.
Yeah, I think one of the things we definitely know is how little we know. And if we have the humility to recognize that, then we can join together to move forward instead of polarizing. What we do know is that it is something not seen before, so none of us had immunity. That makes it a unique setting. Influenza each year, we have some carryover immunity. Not even counting vaccines, we have some immunity within the population that helps to mitigate it. We don't have that. The other thing that we know is that it is highly, highly transmissible through droplets. So close contact, respiration, coughing, all help to transmit it. We also know it can transfer from fomite, not as effectively as by droplet transmission, but still fomites, inanimate objects. It can live on those for periods of time, and we've seen that the studies show it hangs out longer on some of the hard surfaces than we thought it would. And the other thing that we know about it is it has a predilection for susceptible populations, and we've all heard who the susceptible populations are. One of the interesting add-ons to that is people who are exercising aggressively, who get exposed during that time, actually have a propensity towards the pneumonia because their inspiration, their volume of air movement bypasses the normal upper respiratory and upper bronchial response and lets the virus get right to the alveoli, the air sacs in the lungs, and cause disease. So we're seeing that in some young, highly trained athletes. And that's kind of an interesting thing that's making us more aware that this is not as discriminatory a virus as we would have liked to have thought that, oh, it's only our very aged and multi-illness patients. It is a large segment of the population, and now we're looking at some of the Kawasaki-like syndrome in children and some of the other manifestations in children, and we're realizing, again, none of us have immunity. All of us are going to have some form of a response, and we're getting a better picture of what that breadth of response can be. And now we have to fine-tune understanding even more which populations are at risk.
All right. So here's the interesting thing. So I have questions here that are, easier, harder. I'm just going to go through them. And actually, since you brought up exercise and those kinds of things, I approach this from two perspectives. One is, the question is, when are we going to be able to go to a crowded stadium, a sports event, or a concert in the future? That's one question. But the second would be, is it safe for people to participate in a baseball game if what you just described is one of the potential outcomes?
Yeah. As far as when do we get to go back to a crowded stadium, either a truly effective vaccine with a high penetration of immunization in the population, or second, the population at large has had enough disease penetration that we have over 60% of the population having had the virus and then having immunity, if indeed it proves to provide any immunity. They're still trying to figure out, do we have long-term immunity after recovery from the virus? So when either of those conditions is met, then we can crowd the stadiums. In terms of, is there a risk for people in sports? Baseball, a lot less than others because the proximities and contacts are generally reduced. Only times are at tagging, and those don't happen that often, but it's still a possibility. I would think more soccer or football to the rest of the world. Soccer, you're in close proximity frequently and respiring at a high rate. I would think that would be a very dangerous. Basketball, likewise, very dangerous. And, here the NBA wants to come back. Is that going to be safe? I don't know. I don't think so.
Yeah, so if we do, well, I don't want to get stuck on that question because there's so many questions here. I was going to say, if we do testing and everybody in the game is COVID free or not not infectious at that point, is that game safe? Should we consider it safe?
It is a lot safer than if you didn't do testing and allowed just everyone there and maybe had some folks who were asymptomatically infected. However, my concern is that the tests that are so far available still don't meet what we used to consider to be the threshold for sensitivity and specificity. So the false negative rate and the false positive rates are really quite high. False positives, fine, you're going to exclude them from the game. That's a problem for the athlete, but it saves the others. False negatives is a real problem. And when you have 8% false negatives being, quote, a good test currently, that's still too high to really provide mitigation.
All right. So, again, people don't shoot the messenger. I'm just pulling this stuff off of social media and different things that I've read. So 68,000 deaths as of this morning. 30,000 of them are in and around New York City. And the question really is, if you take those numbers out, if you take the New York City numbers out of the total, don't we just have a bad flu season? Is this a big city, mass transportation, high-rise, elevator-centric problem, living in close proximity problem? Because when you look at some of the other more spread out cities like LA, you only have 1,200 deaths, 57 deaths in Orange County, even though there's millions of people there. And those are two places. Keep in mind that they have an awful lot of travel between China and the West Coast. So do we have just a close proximity living problem, a New York and other really close proximity living issue?
We don't. We have a worsening in close proximity, but we have the problem of people who work in roles where they cannot distance themselves, protect themselves, so it can be in a small area. So it is a crowding or a proximity issue, but it can happen in a lot of places that you would not anticipate. North Dakota is, one of the ones the news agencies are going to because the meat packing plant up there and the issues they had. Yes, we would see a lot less numbers if New York was taken out of the equation, but you've got to believe that New York is Chicago, Detroit. LA is spread out. San Francisco is not as much spread out. And so you still have some cities at significant risk. And then you've got areas where you could get pockets of infection, as we saw in North Dakota, and in a smaller population have pretty high percentage of case incidents.
Yeah. So I live in a community. This is, I talked to somebody yesterday, and this is essentially the question they gave me. And we live in the same community. I live in a community of about 1,000 people in Florida. It's a community with a fair amount of retirees. Given the transmission rates and all the things we know, there's 600 confirmed cases in our county. We have proximity to large cities here in Florida. It's not like we're that far away from Orlando, Tampa, and Miami. And the fact is, we never closed the golf course. The tennis courts are still open. Pickleball's still open. FedEx and Amazon, might as well have a racetrack out here. Their trucks are going through the community almost on an hourly basis, as well as contractors are still going in and out of houses and doing work on a regular basis. And so I'm going to really channel my stats teacher here in college. And he would say, what is the probability that no one in this community has COVID and that no one has died from COVID? It doesn't seem probable.
Yeah, and that probability approaches zero. My wife and I were recently in a different location, and in that location, it's a stable population of about 3,000, an itinerant population of 1,500, and had not heard of any cases until late in the stay. And then one of the church members at the Presbyterian Church was reported to have succumbed. And where did that case come from? Was it imported to this isolated area, or was it is there a population with asymptomatic disease in the area? We don't know. And so, it can pop up anywhere. The likelihood that you're in a community that has not seen at least a case is slim and none.
Yeah, and so you would think we'd see something, right? This is an older community. Somebody would be getting sick. Somebody would going to the hospital or something. And essentially what the community has said is, once we have a confirmed case, we will change behaviors. But until we have a confirmed case, they put social distancing and other things in place, but they haven't shut down those activities. But they say, the minute we have one, we're going to shut down those activities. And so you would think we'd have something. Anyway,
it's a tough one. Like I said, in the community where we were, we thought that it was totally isolated, protected, and wasn't going to have a case, and then it did. And then the question is, did you take by having the activities, did you take the Trojan horse into the city wall and say, we're going to push it out once we prove there's Trojans in it? The damage might be done if you wait for it in a population of senior citizens.
Yeah, this question's coming up more and more, which is, we seem to be measuring this disease based on cases, not on deaths anymore. And, we talked about flattening the curve, and that was the whole thing. We're going to flatten the curve. And so now we're getting on the other side, and people feel like the goalposts have moved. And the question really is, do we track the flu based on cases, or do we measure the flu based on, again, how lethal it is and how many deaths come about from it?
Yeah, and with the influenza seasons, we always look at the total number of infected, 29 million, et cetera, and then we look at the deaths, 30,000 average per year. And we track that, and yet we've never responded as strongly. We, in fact, have inadequately responded to influenza over the years because we really could mitigate that more with better immunization, since we do have vaccines for it. And better hand washing, which now maybe we're all good at 20-second hand washings. But our flu seasons could have been better than they've been. And we've been rather cavalier as a nation, but also as a world, about influenza because it's been around. and we're reacting really strongly to this. It's new. There's some good reasons to react strongly, but maybe there's some overreaction. That balance between mitigation and elimination of risk has to be struck. We cannot eliminate all risk in life. We can mitigate. How much mitigation is tolerable and sustainable? And that's an argument for a lot of folks smarter than me and a lot of folks who understand the economics better than I do. But you do have to strike a balance at some point.
Yeah, and so that's where we're going to go next. So this question is actually from me. So I spoke to a health system that has their OR functioning at about 50%, losing a fair amount of money every month, and there's no option for them to really reopen it at full capacity due to government restrictions and other things that they have to get through. But the reality is they have one positive COVID case at the hospital. And, we're in the process of bankrupting hospitals for one case of COVID. Does that really make sense?
Yeah. And it doesn't, and it does.
It doesn't until it does.
Yeah. Right. It doesn't, in that case makes a very good argument for let's go business as usual and survive so that we can take care of all these other things that we're currently ignoring and pushing down the way, because we're going to see cancer diagnoses rates, et cetera, spike post COVID. But it does make sense because we were not prepared to manage this, and because of the structure of our healthcare system where it is a competitive environment. If you have 4 hospitals in a community, none of the 4 from different systems is going to jump forward and say, hey, make me the COVID hospital. We'll take all the COVID cases, triage them elsewhere, dump them on us. We'll shut down everything and you guys go. Well, you could do that, and you would have thought it might have happened in Italy because Italy has a national system and regionalized hospitals, and they didn't have it prepared. And to go forward, I think we're going to have to think about, can we designate places to be the infectious disease? Almost back to the sanitarium days, except for when they're not sanitariums, they have to be fully functioning hospitals. And the rest of us support that hospital that serves as the, quote, sanitarium, so they can be back on their feet when the crisis is over. That's, I think, going to be something that policymakers are going to really have to discuss, is how do we restructure our health system and our utilization of bricks and mortar resources in the US to allow us to respond to something like this without this draconian shutting down of every single site, to the impairment not only of their financial viability, but to the impairment of the population. People not getting screened for cancers, not getting screened for diabetes, not getting screened for cholesterol. You saw the numbers that came out of New York, 68% on some things and 95% reduction in screening in other areas because they're fully engaged with COVID.
So, again, some of these I struggle to even read because I know that people are going to have shudder when I read them. But essentially, we shut down the economy. 30 million people have lost their jobs. 228 health systems have furloughed employees. We have the USA Today talking about the hundreds of rural hospitals that will likely just close and cease to exist. We've sent people home and told them they really can't go back to work. And we've really created a petri dish for domestic abuse, depression, mental health issues, as well as some of the things you're talking about. We're not doing screenings. There's stories now of people literally having strokes at home because they're afraid of going into the hospital and getting COVID. Does that make sense? Is there a way to do this where we're not creating the significant problems on the other side of this?
And again, unbelievably complex. I used to talk about complicated was an internal combustion engine. It's a lot of parts and a lot of things, but an individual could actually learn to take apart and put back together an internal combustion engine and know how it works. One person could do that. No one person can deal with a complex system. And I think that complexity means the conversations are going to have to be carried out around how do we help the system to move forward restructure so that we don't have to shut everything down in the future, and reduce some of the anxiety provoking and sensationalizing that we've seen across media in every direction. If you show us only the worst and you show us scary, scary things about hospitals, and we see the Elmhurst Hospital over and over again, I'm not going into that hospital if I'm a well patient otherwise. And yet we have to have people go into hospitals. It is much more dangerous to stay at home with some facial weakness and slurring of speech than to go to a hospital. Intellectually, we know that, but now we're at an emotional state. We have to help people come back to a less emotional response, and that's really hard. But we have to be able to say, yes, this is new, but no, this is not different than other things we have faced, and it does not eliminate all the other serious health issues that we should be attending to. How we do that, that's, like I said, incredibly complex. I think the AMA is joining in the conversation quite well. I think the other organized medical groups are. I think a number of our state leaderships are. We need to have the conversation. And unfortunately, in the midst of an epidemic, it's very hard to get people to have reasoned conversations. We are making decisions right now that we would never make at other times, whether it's for patient privacy or for accepting tests that are inadequate. We just wouldn't do some of these things in normal times. When we get to a point where we can take a breath, the conversations have to continue. And unfortunately, we have a history of going, got through that, and we move forward.
So I'm going to have two questions. And thanks for doing this. I realize, there's no doctor-patient visit where you're going to talk a half hour with these kinds of questions coming at you. So I appreciate you.
Actually, you'd be amazed.
Really?
You'd be amazed.
So this is pretty normal. Well,
this is pretty normal. That's why my CMA was always at the door knocking, saying, "Dr. Bensema, you have a phone call," just to try to get me to cut off.
So, all right. So let me know when they knock on the door over there. So let's talk. Contact tracing and testing seems to be the playbook that the medical community is throwing around, and the only rational approach for containing the virus. And actually, that's very bipartisan. The contact tracing, testing. The question really is, with 1 million confirmed cases, isn't containment a lost battle already? Why would I give up any semblance of privacy for a cause that is lost to begin with?
Yeah. And so containment is already a lost battle. You're right. But the reality is, if you flatten the curve and in fact can get it to start to decrease a little bit, contact tracing is what helps you prevent the spikes on the go forward. And so I think contact tracing has a real place. If we were in New Zealand, it'd be a little more obvious of a case. They've supposedly eradicated new infections at this point. If they see something, then contact tracing would really help them to contain. But even with 1 million confirmed cases, you can contain further spread by contact tracing and being able to get the testing out and then quarantine those who have been exposed and treat those who've been test positive, which is currently only supportive treatment, right? We don't have any actual treatment. Remdesivir has some promise, but it's, there's a lot of questions about how effective that is. But contact tracing is a way to keep the spikes from coming, control the resurgences that we now anticipate are going to continue over 2 years, or until we have an effective vaccine that is highly penetrated.
All right. So you said 2 years, which leads to the final question, which is, we're saying terms as a society now that we didn't even know back 4 months ago, which is herd immunity. So we hear this whole concept of the only way to get to the other side of this is through it, right? To get enough of the population that has either recovered or has some semblance of the antibodies built up within them. And there's a couple ways to do that. I mean, you have the now famous, I guess, Sweden is heading through it. Just, they haven't closed their schools. They're practicing social distancing, but they're doing it at a different level than most others. They're saying, we're going to get to the other side of this. I don't think they're publicly saying that, but it would appear that that's their strategy. And so, but the other side of this in the U.S. is we keep hearing, a year and a half until we have a vaccination. And, I hear the word 2 years. I hear a year and a half till we have a vaccination. I hear the only way through this is herd immunity. And I go, are you kidding me? Are we going to live like this for the next 2 years? And is that even possible? I'm not sure that's the question. The question for you is that the case? Is the only way through this that enough of the community builds up an immunity? And what does the path look like to get from here to a point where we have enough immunity built up within our society?
So if you go the herd route without a vaccine, it looks like the total number of deaths that was originally projected, and that's in the millions, 1 to 2 million deaths across the U.S., and you could get to herd immunity. The question there, and the one I don't have an answer to, and I haven't seen an answer in the literature yet, is having gotten through that and essentially sacrificed that many individuals in our population to get there, would you actually have immunity? We don't know that yet. That's a huge question out there to be answered. Does having had the infection actually grant immunity for an individual? So then the next part is, can you sustain this for 18 months? I think because we have such variable approaches, we're going to continue to have the huge amount of contention. I think change facilitation, I always hate the word change management because that still implies that I'm controlling you. But change facilitation, me helping others to understand that simply wearing a mask when out in public and keeping social distance can allow us to get back to a lot of activities, can allow us to restart the economy, putting in place some of the barriers, et cetera, at workplaces to protect workers, can allow us to get back there. And I think that's how you get through the 18 months is with those measures, recognizing they're imperfect. And that's where contact tracing then comes in. So you can have some further mitigation behind that. The real question is, that's expensive. That daily cleaning in everyone's office and everyone's store, that's expensive. PPE, expensive. And those are added costs of doing business at a time when you're making less revenue. And how do you get through that economically? I think those are big questions. And like I said earlier, it's going to take a lot of folks, a lot smarter than me, but with a calm voice and with a real desire to help and a real desire to engage everyone in helping, because I don't think this is something you get through with directives or with I know better than you, you do what I say type approach, or, we're going to just stick our head in the sand and it's going to go away approach. Neither of those works. But how do we engage each other and really appeal to our better angels to do what's best for one another? Golden rule still applies.
Yeah, as is usually the case with you and I, we're going to end this episode because it's coming up on the max that we like to do for an episode. But you and I are probably going to talk for another half hour on this topic because and I really appreciate your time today and talking through this. And as part of the prep, I had to go out on social media and read this, just read the social media post. It's brutal. I mean, people are talking, but no one's really listening. We've set up sides on this. On one side, you trust in science, and on the other side, I guess if you don't trust in science, you're just you're I don't know, ignorant. And the social media posts almost come off as that. It's so divisive at this point, and it makes the situation that much harder to try to get a cohesive strategy across the board. It's impossible to answer when all the planes are going to be back in the air and when I'm going to feel safe getting on a fully packed plane, or when I'm going to go to the next baseball game and sit in a crowded stadium. Those are impossible things, and those are probably the last things we're going to see in this. But on the flip side, I feel the pain of some of these social media posts. I mean, I've been furloughed. Do you see a future where I get brought back? And we don't have answers right now for that. But I wish we would at least show some empathy as we're trying to explain the seriousness of the disease and the potential ramifications of just ignoring the medical community on some of these things. It's we can find a path through as long as we're going to talk and listen to each other. David, thanks again for your time. I really appreciate it.
Appreciate it. Thanks for having me.
That's all for this week. Special thanks to our sponsors, VMware, Starbridge Advisors, Galen Healthcare, Health Lyrics, Sirius Healthcare, and ProTalent Advisors for choosing to invest in developing the next generation of health leaders. If you want to support the fastest growing podcast in the health IT space, the best way to do that is to share it with a peer. Send an email and let them know that you value and you are getting value out of the show. And also, don't forget to subscribe to our YouTube channel while you're at it. Please check back often as we will continue to drop shows until we get through this pandemic together. Thanks for listening. That's all for now.